Hello everyone, good afternoon. My name is Amarachi Gold and I will be taking the tutorial for Rehabilitation Psychology Sci 434 this semester. So today we're going to be talking about Rehabilitation Psychology, approaches used in Rehabilitation Psychology and assessment in Rehabilitation Psychology. So firstly, what is Rehabilitation Psychology? Rehabilitation psychology is a specialty area that aims at maximizing the independence, the functional status, the health, and social participation of people with disabilities and chronic illness. Now, what is the main aim of rehabilitation psychology? Maximizing independence. We want these people with disabilities to be able to function at their optimal capacity. That is what rehabilitation psychology aims to do. It aims to help people with disabilities to function at their optimal capacity. Rehabilitation psychology aims to help them physically, psychologically, emotionally, cognitively, and socially, because there are challenges round all these areas of a person with disabilities life. So when you are a person with disability, it's not just rehabilitation psychology understands that it's not just this individual having problems or having challenges with their disability. This disability is affecting every other area of their life. This disability is affecting them physically. This disability is affecting them psychologically. This disability is affecting them cognitively, emotionally, socially. So rehabilitation psychology aims at helping them in all those areas of their life, not just helping them, with their physical area, which most people focus on, but helping them with all areas of their life. And they usually work in teams. Rehabilitation psychologists, they don't just work alone. Sometimes they work in teams to give like a more comprehensive care, a more holistic care to the patient or the person with disabilities. Now, approaches in rehabilitation psychology. The first approach we're going to talk about is the biopsychosocial model. Now, this model explains what I just said. I talked about the fact that most times we think that helping a person with disability is focused on helping them physically. So this is just like the biomedical model. This biomedical model talked about how to, help, disabilities, how diseases, illnesses are from the biological side. It talked about how genes come to play, how it is medical, how the care can be medical, treatment by drugs, all those things, running tests, but it did not talk about the other areas of life. And biopsychosocial model was created by George L. Engel in 1977. He looked at this biomedical model and he realized that it wasn't really making sense. It wasn't really right that we are streamlining ourselves to focusing on an individual's biological factors, and we are not looking at other factors that are affected by this disease, by this illness, and in our case in rehabilitation psychology, by this disability or chronic illness. So he was like, what do we do? He published a book called The Need for a New Medical Model. And that was when he brought about the biopsychosocial model. This biopsychosocial model, just like the name implies, it focuses on three things. What are those three things? Biological, psychological, and social. So biologically, an individual with disability can be affected biologically. Like now, somebody that is born with trisomy 21. It's biological. You see, that is the biological factor. That's the genes playing a role in it. Now, you can also treat disabilities medically. You can treat chronic illness medically. Like maybe a person with cancer, chemotherapy. Those things are medical ways of treating disabilities and chronic illnesses. Now, psychologically, these disabilities and chronic illnesses can distort an individual's mental well-being. So an individual with a disability can be affected mentally. They might develop feelings of anxiety, feelings of depression, because they are not able to, do certain things that they used to do before. And that leads us to the social factors. Now, imagine a patient with cancer that used to be a star basketball player in his school. He used to throw hoops, used to play, used to do all those things, and it was a thing of pride for him. and now he is diagnosed with cancer. He is unable to play. He is unable to do those things which he loved to do. This is a limit on his social participation. That explains the social factors. So it can limit your ability to engage in social activities. Discrimination can also occur, which can also lead to social withdrawal. Your environment, they might not be the friendliest to you as a person with disability, and that is where social factors come in. So we cannot just think about disability with the biomedical mindset. We have to spread. You understand that is a more holistic view to disabilities, understanding that there are biological factors, yes, but there are also psychological factors, and there are also social factors. Then we have another model, which is the psychoanalytic model. Now, the psychoanalytic model, we have talked about psychoanalysis a lot by Sigmund Freud in the 1890s, and we talked about how it was based on the unconscious. So Sigmund Freud, in this theory, he is telling us about how repressed memories, unacceptable memories and thoughts, they are the deepest parts of the mind. There are 3 levels of awareness. There is the conscious, which are the ones that are present in our awareness. There is the preconscious, which are not present in our awareness, but we can easily bring out. And there is the unconscious, which are deepest level. And that is, the basis of psychoanalysis. Also, we talked about components of personality, the id, which is the primitive pleasure principle, the ego, which is the mediating between the id, it's the rational reality principle, and the super ego, which is the morality principle. It's focusing on doing things in accordance to laws and norms. Now, we also talked about the psychosexual stages. We have the oral stage, we have the anal stage, we have the phallic stage, the latency stage, and the puberty stage. Oral stage has its erogenous zone as the mouth. Anal stage has its erogenous zone as the anus. Phallic stage has Oedipus and Electra complex. In latency stage, we have a period of rest. Then in genital stage, the erogenic zone is the genitals, or are the genitals rather. Now, in these psychosexual stages, we're going to talk about the phallic stage. And in the phallic stage, I told us Oedipus complex and Electra complex. Oedipus complex is experienced by male children. Electra complex is experienced by female children. Now, during this Oedipus complex, they can experience what is known as castration anxiety. What is Oedipus complex, first of all? We can define Oedipus complex as feelings of jealousy and feelings of attraction. So they feel jealousy towards their same-sex parents, which is boys feeling jealousy towards their fathers, and feelings of attraction towards their mothers. Vice versa in the Electra complex. And they might not be able to act on these feelings of jealousy. Why? Because they are afraid. This is castration anxiety. Now, castration anxiety is an unconscious fear about the loss of one's genitals. So they may have an unconscious fear about the loss of their genitals. And then, this fear, we can relate it to rehabilitation psychology. Now, in rehabilitation psychology, there can be a loss of physical functioning. I talked about the cancer patients that might be unable to play basketball anymore. There might be a loss of physical functioning, a loss of his ability to engage in social participation. There might be loss of independence, loss of control, and this can lead to anxieties. Anxieties about feelings of worth, anxieties about your value, anxieties about your place in society, anxieties about your independence, anxieties about your control, which can later lead to a lot of mental health issues. They might struggle with adjustment. And adjustment is the last stage in Jerome Stiller's theory of adjustment. And that theory is trying to, see different stages which a person with disability can go through. We have stages of disbelief, stages of anxiety, stages of denial, stages of internalized anger, all those stages. And then the last stage is adjustment. Now, this adjustment stage, it is hard because they might have this fear that I have lost something that I enjoyed doing, something that I enjoyed participating in, something that I loved so much. I am no longer able to do it. And rehabilitation psychologists have to help them to overcome this fear. That's why, we talked about rehabilitation psychology trying to maximize independence, because they might feel like they have lost their independence. They are no longer in control of the activities that they engage in. Maybe they have put them on a strict treatment plan or a strict diet. So it's no longer the spontaneous wake up that they usually used to do. So if you've watched this movie, Me Before You, there is this man called Will, and in that movie, it shows how he struggled with his anxieties. So he had an accident which led to his disability, and because of that, he had struggles. He had struggles understanding how his new life was. He had struggle adjusting to this new life. And that happens with a lot of people with disabilities. They struggle with adjustment. They struggle with being able to they struggle with their self-esteem, their sense of self, because of what has happened to them. They can struggle with their value, their worth. Maybe they feel like there is no place for them in society, maybe because of discrimination or all those things. And that brings us to our third model, which is social psychology. Now, social psychology, the father of social psychology, Kurt Lewin, in his field theory, he explained that, let me put it in words, he said that there's a dynamic interplay between an individual and his environment, and that interplay leads to shaping behaviors. Now, let's look at it. That means an individual interaction with their environment shapes behavior. When a person with disability experiences stigmatization and discrimination from their environment, how do you think they are going to behave? They might have social withdrawal, where they do not want to engage in the society again. They might develop feelings of anxieties and depression because they don't feel wanted, they don't feel loved by the society. A lot of cultures, they might regard them as an osu, an abomination, a taboo. You cannot do this to them, you cannot sell to them, you cannot do this, do that. All those things, it affects how they behave. So we have to understand that socially, people with disabilities can face a lot of challenges. They might find it hard to integrate into social establishments, social activities, because, for example, now, if their social environment is devoid of architectural structures that can help them to live independently, then they might find it hard to integrate into that environment. Imagine living in a place where maybe there are no slopes, and as a person with disability, a person with like an impairment, you are unable to move. You need somebody you're always looking for help, somebody to carry you throughout that stairs. Imagine how that would shape their behavior. They might no longer want to come to that place, because every time they come there, they struggle. So they might not feel excited, they might not feel happy to come to that place. You can see how it is shaping their behavior. This structure in place, this structure in the environment is shaping their behavior. Or maybe every time they come there are people making snide comments, snickering, looking at them with one eye, trying to see what's going on. Those things can change their behavior. They can make them not want to come there. It can make them feel sad about coming there, feel anxious if it's something that maybe they actually cannot avoid. They might feel anxious about coming there. It can also affect their adherence to treatment, because imagine being in a situation where they are continually hearing negative things about themselves, and then they internalize these things. So let me push that to the cognitive behavioral therapy, which is the fourth model and the last model we're going to be looking at. Now, in the cognitive behavioral therapy, we know that it's a psychotherapeutic treatment that talks about how there are destructive thought patterns that we need to change, because these destructive thought patterns can lead to maladaptive behaviors. Now, cognitive restructuring is one of the most important parts of cognitive behavioral therapy, because we need to change these thought patterns. We need to identify and challenge these negative thought patterns in order for us to bring about a change in behavior. So, like I was saying about the side comments, the pointing and all those things, negative things that they might have heard people say to them, when they internalize these comments and believe it, they have made destructive thought patterns. Maybe somebody has told them continually that they are useless, they are worthless. They might accept this as a fact to themselves, that, oh, I am useless, I am worthless. And how would this make them feel? This can inhibit how they attend to treatment, because they are like, I am not going to be able to achieve anything either ways. So what is the use of me taking treatment? What is the use of me adhering to this treatment plan? What is the use of me taking my medicine? What is the use of me going to visit the doctor when at the end of the day, I am not going to be able to achieve anything in life? You know, it might hinder their progression. It might hinder their motivation. They are no longer motivated to do anything. They are no longer motivated to participate, because they feel like they are not going to be able to achieve anything either way. So cognitive restructuring is important. And also problem solving skills. You know, we have to make sure we are challenging these stressors in their life. We're addressing them and we are challenging them. We're challenging physical limitations. We're challenging emotional distress. We're challenging social barriers that are faced by people with disabilities and chronic illnesses. Another thing I wanted to talk about in social psychology, which I just remembered, is how their social network is important in helping them. So people with disabilities, they need a strong social network. They need, you know, their family members by their side, their close friends by their side, because they might feel like they have nobody in the world. They might also need people to help them with things that they are now physically limited, with things that are now limited to do physically. Like maybe they might not be able to do certain things and they need help to do those things. If they do not have a strong community, if they do not have people who are there for them, this can also lead to feelings of anxiety and depression, because they feel like, now I am unable to do this, or I have always been unable to do this, and it's like there has never been anybody to help me do it. Why am I even here? Why am I even around? You know, they can have feelings of depression, feelings of anxiety coming from this lack of social network, lack of community. And you know, community is important in everything. Community is important in how people grow, how people live, how people behave. Now, assessment or in rehabilitation psychology. Psychosocial assessment is very important. Now, we want to assess how the person is doing socially. Like I said, their social network, their family dynamic, their community involvement, their access to resources. We want to assess these things. We also want to assess them psychologically. We know the use of psychological tests to check whether an individual is doing well or not. Cognitively, we want to assess impairments that might have come with the disability. We want to assess their attention, their memory, their executive functions, their language, etc. And one thing that cognitive assessment does is that it helps the therapist to be able to communicate well with the what would I call it? With the client. Yes, that's the word I was looking for. It helps the therapist to be able to communicate well with the client, because you know, in clinical interview, we have always talked about bringing yourself down to the level of the client. Because imagine a client is speaking in pidgin English and you are speaking in some big grammar that they don't understand. How will the therapeutic relationship be? How will they flow with the words that you are saying? They will not be able to understand what you are telling them, because you've not assessed the language of this client. Another thing is behaviors. You know, we're assessing the behavior of the person, we're assessing how they act, we're assessing their adaptive and their maladaptive behaviors. For functional status, we're assessing their day-to-day being. So their daily functioning, we're checking it, we're checking how they behave, their physical, their cognitive functioning, we're checking all those things. Their self-esteem as well. You know, people with disabilities may experience feelings of inadequacy, low self-perception. So we need to evaluate that as well. We need to know how it is, because these things can hinder motivation, it can hinder treatment, just like I said previously when I was talking about cognitive restructuring. We have to assess their coping skills as well. How do they respond to challenges? We have to make sure we are assessing that, we are knowing that, so that if we are identifying ways, poor ways or negative ways, such as maybe self-harm, that they are using to cope with these challenges, we know that this individual is engaging in a maladaptive behavior, and we are going to try to impute a treatment plan that addresses that. We're also assessing their quality of life, which is their overall well-being. So in the second video, we're going to be discussing clinical assessment for people with disabilities. Is it clinical assessment? Yes, clinical assessment for rehabilitation of people with disabilities. Thank you very much.